Good afternoon. My name is Matthew Clay, and I'm with JBS. Thank you for joining us for today's webinar, Improving Data Collection and Reporting, a Learning Collaborative. Before we begin, I'd like to review some housekeeping items. Due to the high number of participants on this call, all participant lines will be muted for the duration of this webinar session. If you have any comments or questions, please submit them at any time by using the Q&A feature. To open your Q&A window, please click on the Q&A icon located in the bottom center of your Zoom window. Closed captioning is also available. You can view the captions in your browser by clicking on the AI media link in the chat, or depending on your screen size, you can go to the ellipses at the bottom of the screen below More to show captions and change their size, or use the caret beside the closed caption notation at the bottom of your screen. If you experience any technical issues during this webinar, please message us using the chat feature, which is located at the bottom center of your screen, or email us at samhsastateta@jbsinternational.com. Lastly, this is a recorded event, and your participation grants consent to be recorded. The recorded webinar and PowerPoint slides will be available at a later date. Next slide. The views, opinions, and content expressed in this presentation do not necessarily reflect the views, opinions, or policies of the Center for Substance Abuse Treatment, the Substance Abuse and Mental Health Services Administration, or the U.S. Department of Health and Human Services. Next slide. I'll now turn it to Talisha Searcy, Director of the Office of Performance Analysis and Management at SAMHSA, to provide this afternoon's welcome. Talisha, the floor is yours.
Welcome. Well, I'm so excited to have the opportunity to continue to participate in the Learning Collaboratives. I want to thank you all for your commitment to advancing the Substance Use Prevention, Treatment, and Recovery Services Block Grant Program, or SUPTRS-BG, as we call it here at SAMHSA. SAMHSA's draft strategic plan highlights the agency's commitment to using data and evidence as a guiding principle to ensure that programs are achieving their intended goals. The work that you have done over the course of this Learning Collaborative will inform how SAMHSA can collect, share, and use block grant data to improve the SUPTRS-BG program. Specifically, SAMHSA will use this information to inform future resources to aid grantees in funding data collection activities, and program reporting requirements with an emphasis on reducing grantee burden, as well as support data analysis and information sharing on the impact of the SUPTRS-BG program. So again, welcome, and we look forward to continuing to work collectively with you to improve SUPTRS-BG data collection. Thank you.
Dr. Grams, we'll now turn it to you.
And I remembered to unmute. I'm very proud of myself. Already we've succeeded. We have a slide here intended to tell you a little bit about the path that we took to get where we got today. But I actually want to back this slide up a little bit, all the way to 1981, when Congress launched the block grant program. And I think one of the things in the launch of the block grant is also an issue that we face today, something that historically has followed the block grant, and that's that Congress set up the block grant to fund capacity, not to fund each individual person going through a treatment program. So all of the systems that we set up way back then were intended to keep track of capacity, not that we funded this person, this particular person's care. Instead, we kept the doors open so that person could be cared for. So I'm going to go fast forward a little bit. After the program was going and we had our systems in place, we'll come to 2003, actually, where there was what was called at the time a program assessable, and the block grant did not do well in that assessment. That led to further evaluations that you see on the timeline that we have right now, where we were asked to do, not we, but CSAT hired an independent evaluation of the block grant program. And they had several findings in there and recommendations for improvement, but the idea that we need to be able to accurately point to the individual whose care was funded by the block grant seemed to be pervasive throughout some of these reports from the GAO. And so with that in mind, that our systems develop in a different way than our systems are needing to be developing today, we're embarked on an effort to figure out really how the states collect and report their substance abuse prevention and treatment block grant data and recovery. And also how then can we improve the systems that enable the collection of those data, and how can we actually improve the quality of those data, always in mind that there's more of a focus on individuals that have been served, as well as, I don't think that emphasis on what our system or program capacities are has ever gone away. So I'll take you up to about, I guess it was around 2016. We had an election like we have every 4 years. And that led to some restructuring around the way that the block grant is managed and governed. And it also led to technical assistance and training contracts going away for a time. After that, the GAO issued another report for us about our data quality that kind of set us on the path that we're on today. And in 2022, they found that, I'll just read the quote, without reliable data on the number of individuals served from the SABG program, that they could not assess the overall achievements of our treatment system. So that's the path that we're on now. CSAT has started us on this path to evaluate, improve, and go forward together on a path toward high quality block grant data. All right, go ahead. So my name is Gwen Graham, so maybe I should have reversed the order on this, but I, for 10 years, was the data technical review specialist on the Core Technical Reviews project. So in that capacity, I got to review, provide technical assistance, or in some cases, I actually worked in 49 of the states. And so if Iowa's here, Iowa, you are my missing state. I'm thinking I might do some volunteer work for you if you want me to. Go ahead. Forward. All right. So the mantra that we have put forward for our learning collaboratives, or the effort that we're going through here today, is we want a system where we all teach and we all learn about data practices. But it's most important, and I think we came up with a second mantra as we were going through this. So everyone teaches, everyone learns, and our sub mantra is states are different. And so we're going to teach and we're going to learn in a little bit different ways. And something that really came out strongly throughout the collaboratives, because something worked in New Jersey, it might not work in Kansas. What works is very dependent on the system that is set up to support your data, all of the different things that go into what your state system is. So what we're going to be presenting today or trying to talk about are overarching strategies that we know are associated with high quality data, which will tell you how we've defined that. But we also want you to know that it won't work straight off the shelf from one state to another. It's always got to be adapted to your unique situation. All right, go ahead. So here's today's agenda, and we'll consider number 1 done. You are welcome, and we're very glad you are here. You have a little bit of the overview of the Learning Collaborative, but I'll give you a little more as we go. We're going to talk about the what we learned in the collaboratives and what we discussed during the collaboratives. And the biggest piece of feedback I can tell you I got about this section of the presentation is that I should try to keep myself as short as possible, because everyone would really, really like to hear from the states. So I'm going to do my best to do that. And then we're going to just very briefly, when we're all done with the state spotlights, go through questions and answers and just talk about what might be some potential next steps. All right, go ahead. So just so you know, everyone who's here today, essentially 3 different kinds of players who are here. We have SAMHSA, who we are very grateful has sponsored this set of learning collaboratives. And their role here is going to be to listen and learn. And they have really, really gotten that into my head. We want to be here to learn from the states, like all the states are here learning from the other states. But they will also provide us with support and information as we need it. JBS here is just here to organize things and to capture everything and to make sure that it's archived. And then finally, you are here as the states to set the agenda and lead our discussion. All right. So our scope today is web BGAS data. I think block grant application system, I got it. Those are 3 kinds of data, and the categories are broad. That you have client, service, and financial data, essentially feeding web BGAS. We want you to know, though, even though we focused on the web BGAS data, the principles that we discuss here will work with almost every data set that you would want to apply them to. All right, go ahead. All right, so I'm going to describe very quickly, if I can, what we talked about, big overview in the learning collaboratives. We had 6 of them. And then we're going to introduce state speakers who will address some of the specifics of what we discussed. So I'm actually going to take the first section talking about data quality framework and data quality measures. I was actually really encouraged by the way I thought our state group coalesced around a definition of data quality and a definition of how we might measure it and how we might implement practices to improve those characteristics of data quality. We're going to go from there, and Laura Heaven is going to lead us in a discussion about setting clear expectations for providers. Excuse me, one second, sip. And how we target communication. We'll go on from there to talk about working with data partners. We'll show you a list of potential partners and talk about matching methodologies, or what we mean by that, methodologies used to take disparate data sets and put them together so the data within them can be analyzed together. And for that discussion, we'll have Andrea Kimball from Missouri, and I think I got it right, will be leading us in a discussion on that. Then next, we are going to go with working with data partners, talking about improving data from the bottom up. We'll be talking about incentive payments and performance reports, and we will be hearing from New Jersey for this section. We'll follow that up with a discussion about capturing the client's recovery journey. And for that, we will be hearing from Brittany in Georgia about a remarkable program that Georgia has implemented, and all of the states within the Learning Collaboratives we're very excited to hear about. And then finally, we're going to tell you about telling a story with our data. And Rana and Sissy from Kansas are going to be telling us about that. So unless there are any questions about that, we'll just go ahead. And one thing I'm going to be doing a lot is asking Matt how we're doing on time. So how are we doing, Matt?
You're perfect, right on track.
Okay, all right. So the first thing we want to talk about is examining state data systems. Go ahead. This was the way we started out together. Our task for that first Learning Collaborative session was to define data quality, agree on a framework for defining data quality, identifying performance measures to assess that quality, barriers that may stand in the way of achieving high quality in our data, and then sharing best practices and information. I'm going to keep saying this. I've said it once before, but we always have the caveat here that we agreed on a framework and performance measures and barriers, but the specifics of those things, the detailed implementation within each state is going to be different just because of the way the state's set up. So what we're going to be talking about are the overarching strategies. The other thing that we recognize in setting the tone and coming through this is that state data systems don't change overnight. Change is a long process. And to change, you have to start with what you have now. So getting from where you are to where you want to go. And that's something that's going to take some work on the part of the agency. One of the things we discussed just very briefly, and hopefully we can talk a little more, is how we do mapping on the processes that go into our data, and how do we truly understand the characteristics, the measures, processes, and best practices that lead to quality data. All right, go ahead. So go ahead and click a lot. I attempted to make an automated slide here, and it turns out it's best just to let the automation happen by itself and me to just talk. But so what you have in front of you is a visual of what the Learning Collaborative used to define high quality data. We said that high quality data has 6 characteristics, and those 6 characteristics taken together like these cogs in the wheel will eventually yield data that are useful. And we define useful here as helping me to manage my program, but by manage, we're taking a very broad view of that. So improve performance, go out and look for funding, all the administrative things that you need to do with your data. So I'm going to just really quickly go through these 6 characteristics we identified, remembering they'll lead to useful data. I'll tell you a little bit about how we think they can be measured, again, knowing that you can only measure something where you have the data to measure it. So if your system doesn't allow you to use any of these measures, you have to start where you are. So that said, we identified that the 6 characteristics of high quality data are that they are timely, accurate, consistent, relevant, complete, and integrated, or integratable maybe. Really quickly, we'll tell you what we meant by those things. The timely data mean that the data are there when you need them. It's really easy to confuse the timeliness of data with the fastness of data. Fastness is something that we know in some ways can be associated with negative outcomes for some of the other data characteristics. So an emphasis on getting data really fast can sometimes degrade data accuracy or data completeness. So when you're thinking about how you use measures and the characteristics of data, they always have to be thought of in the context of how they work together. And keeping on with that theme, so we talked about accurate data are data that reflect what really is, the reality. And accuracy and consistency are two related cogs of that data wheel. But if something happens, say back with timeliness, that causes your accuracy to drift, you can find that your consistency may also diverge. So just keeping that in mind and thinking all the way down the row with how these things are related. Some of the measurement strategies that we were recommending for these measures, we're actually talking about timely data, looking at the proportion of data that are there by the deadline, by the time that you have said you need those data. Accurate data have been measured by the percent of data within a data system that have inconsistencies. Other states have used site reviews to go out and measure the accuracy of data. So they'll say, here's what the chart says, here's what my database says. Do those two things match? And can come up with the proportion of that. Another strategy is fairly new for measuring accuracy of data, though, is through the component of having linkable data. When your data can be linked to extant data sets, that can give you a good gauge of the accuracy. What I mean is, if you know that your data say this client was in the criminal justice system, when you link, you don't see any evidence of that. That's something to investigate. You don't know which database is right, but it's a flag. Am I doing okay, Matt? All right. So the next component is relevance. And this is really, do the data give me the answers to the questions I need answered? Relevance is a little tougher to measure, but one of the most effective strategies I've seen for relevance is actually keeping a database of the requests that you get for data. If you keep that kind of a database, you can start to see the patterns and trends like, oh my, all kinds of people are asking for this thing in that way. And it'll really be an informative mechanism for you to start tracking how relevant your data are. Complete has two components, and it's important to distinguish. Complete can mean you have all of the different pieces of data that you need. So I answer the gender and the age and et cetera, et cetera, et cetera. But it can also mean that you represent all the populations you need to represent. This is one place within the block grant where we have some inconsistency in the way data are interpreted. And in one of the things that the GAO has brought up for us, states have different ways of approaching who gets reported into the databases. And so the way that your state chooses to interpret it, who must be reported, is an important component of your overall data quality. We talked about linkable, so I'll leave that there. What we mean is that your data are organized, structured, and identified in such a way that you can reach out to other data sets and use their data as a companion to the data you have in your system. All right, I think we got that. Unless there are any, I don't think there are any questions. Matt, did you have anything for me? Oh, great. So I think we can go on then. Our second learning collaborative talked about setting clear expectations for providers. And go ahead. Specifically, we talked about how responsibility is made clear to subrecipients, several mechanisms, contracts, policies, performance reports can specify how the data should be made clear. What type of quality control do you have on the data? And what do site visits entail? How do you use site visits within a quality control system? And then really, what are the incentives for good reporting? How did the states make it in the providers and the reporters' interests to report when they should and what they should? All right, go ahead. So this next slide was a real revelation to me. We talked about how we direct our communications to the audience, because our audiences all have such different interests, and really what someone within provider organization working on administration versus working on clinical issues, they may just care about very different things. And the messages that will get through are the messages that talk to people about what they care about. So we made some big generalizations here about different kinds of message recipients and what they would most likely be interested in. And I'll tell you, for me, what the shock was from this during our learning collaboratives. We talked about 4 categories of messages. So messages, time? Oh, so I thought you said something, Matt. How do we get money? How do we fund? How do we do planning? How does data help us do planning? How do we improve our services through data? And then all of the other kinds of things that data can help us do, like administration mechanics. We actually called these other communications. What really surprised me during the data collaboratives, I think throughout my experience in state systems, my number one concern was always, how do we find funding? So messages that talked about getting us money tended to resonate with me. What we found in our data collaborative, though, when we did a poll of our participants, the thing that they found to be most interesting and the most effective message, basically across all of these different groups, was how do we use data to improve our services? I would say there was a really firm and strong commitment shown from the collaborative that needs to be the focus for our data work and for our messages about quality data. So that said, and no questions, go ahead. I have the great pleasure of introducing Laura Heaven, who is with the District of Columbia, Department of Behavioral Health. She is the Director of Data and Performance Measurement. And Laura, I'm going to let you take it away.
Thank you, Dr. Grams. Thank you for the opportunity to present. First, I want to share a couple of notes on DC's Learning Collaborative experience in case anyone is thinking about taking advantage of the next opportunity. It was particularly timely and helpful to hear how other states collect data from providers, including both the challenges and the best practices. We are in the process of a major systems overhaul and are excited to use what we've learned, things to avoid, things to include, as we build our new process for data submission. And it was very helpful to hear how other states work with their planning councils to generate data-driven recommendations. We are about to begin our next cycle of needs assessment and strategic planning, and really want to prioritize including our planning council in that process, and also in establishing more ongoing opportunities to collaborate with them. Next slide, please. But on the theme of setting clear expectations for providers, I'll share an example of how DC has collaborated to improve performance on key indicators. We have a number of KPIs that we regularly share findings with our providers and programs on. When those performance expectations are not met, we've held work groups to work on what's happening and what we can do to improve. Specifically, in recent years, we have worked on our metrics around step down from withdrawal management and residential levels of care. And in those work groups, we would look at performance issues. Was it data quality? Was it practice issues? Was it systems issues? And based on those drivers, we establish a shared performance improvement plan. Initially, we saw improvements, which was great, but over time, performance declined again. And so some of the lessons that we've learned include that repetition is essential. Staff turnover is high, even with the same people. It helps to share the same data points consistently, including trends over time. Clarity around the logic of what is being measured is essential. As performance declined, we re-engaged with providers and based on their feedback, discovered that there was kind of a gap in workflow. There was a group of clients that were stepping down into programs that were outside of our network and we weren't capturing those. So we changed our data collection system and the logic of our KPI to account for that, and performance did indeed go back up, which was great. And then we also learned, as Dr. Graham said, targeted communication is important. And we've learned that providers don't want to talk about data for data's sake. It has to be meaningful for them. And we need to stay focused on the benefits for the people that we serve and why performance improvement activities help clients in a meaningful way. Next slide, please. So in terms of quality assurance, I'll share a little bit of work that DC has done in that area. At the moment, we are fortunate to have a shared platform that all providers enter both their clinical and administrative data into. So data are sort of automatically validated because the system does not allow you to enter invalid options. So we don't have a lot of data quality issues on our TEDS feedback. But when we do, generally it relates to unknown values. And we do share that with providers in those quarterly meetings that we have. But our challenge is really around incomplete data. Providers are not consistently submitting their discharges, and you can't improve the quality of the data you don't have. So as we are decommissioning this shared system and moving to a portal for TEDS and other data submissions, we're excited that portal will have similar robust error checks. But we're concerned that if providers can't pass those error checks, we'll get even less data if they cannot resolve those errors. So really making sure we have solid documentation on this new portal, how to use it, a TA to support them. And then we intend to use claims data to match against the monthly portal submissions to identify if there are folks who are receiving services but haven't shown up in that portal data to see where there are some gaps, and follow up with providers to give them technical assistance to make sure everyone's data is submitted. So as I mentioned, we learned a lot from this learning collaborative, and using this particular example, are very excited to apply what we learned in our new system moving forward. Thanks a lot.
All right, I was not successful on the mute thing this time. My apologies. Thank you so much, Laura. And I should have backed up just a minute before introducing our state speakers to just let you know, we tried to get a diversity of practices and ideas to share with you. So that was part of our selection criteria. But we also asked speakers that we thought were going to do a pretty darn good job making their presentations here. So all of the speakers here, we're so grateful, and we do appreciate how much thought you have put into these presentations. All right, so that said, going on, our next slides, or our next session, we're talking about successful partnerships. And how do we work with data partners? What are the mechanics? And we did also have a specific charge to talk about the Medicaid partner. and a request to figure out Medicaid billing. And we were not able to address that one, but understand that there's a great desire for information about this on the state's parts. But Medicaid can vary quite dramatically from state to state. So we focus more specifically on other partners during the collaboratives. Go ahead. So here are some of the potential partners that we talked about, and you can see the list is long, and it is definitely not all inclusive. I won't talk very much about these because it seems like in a lot of cases, the partner relationships and why they're important are fairly self-evident. Just wanted to point out one partner that's down here, public health and vital statistics, because I think this is an often overlooked source of partner information, but this can tell you about births, it can tell you about deaths, and it's really critical within a system where we're watching our clients to be able to know about both of these things. And I think sometimes we don't realize those data are collected by our states and are usually linkable to our data. All right, so that being said, we're just going to let the states talk from here on out about how to successfully partner and about successful data partnerships. Andrea Kimball, who is the Director of Quality and Compliance with the Missouri Department of Mental Health, the Division of Behavioral Health. And Renee, oh no, Renee, I practice pronouncing.
Rothermich.
Thank you. Renee is also here with us and will be answering questions if we have any questions to answer about that. So, Andrea, take it away.
All right, thank you so much. I love that Renee is here. She's my big brain. So I talk more globally and from a policy standpoint, and she can really get in there and dig in with examples. So I really want to highlight her importance here, but really just wanted to share with you our key takeaways as we participated in the Learning Collaborative. Really, it reinforced a lot of things that we're doing well and things that we want to continue to develop and build on. Definitely creating measurable outcomes by refining decision-making and improving processes. Because it's not enough to just say, hey, we've made it, right? We have to refine those. Integrate with data sets from other state organizations and outside entities to understand the whole picture. That continues to be a process, right? And you kind of highlighted that, Gwen, that there's different nuances. Collecting data on staff turnover to implement necessary training to ensure data quality and consistency. You would think that this is like it's not really mind-blowing, but it kind of is mind-blowing because it's not everyone doesn't speak the same language as we talk about data. So really understanding the staff that need to be there to support that. And then also clearly defining each data point collected, its source, time frame, and caveats, giving context to the data for non-professionals. So really looking at people in different roles within an organization or within the department that you're working with and how you can work with them most effectively. Next slide. So I'm going to talk to you a little bit about what Missouri does and kind of our approaches to how we work with our partners. But really the important piece, and I hope that you hear this throughout everything we talk about from the Missouri perspective, is that our data partners are part of our team. They are not siloed or othered. We go from the approach that we meet with them on a regular basis. We show data comparisons to similar partners, and we will help with the data improvement plan if necessary. We also use tools as much as possible to help monitor data. So an example is the Missouri 988 Tableau dashboard that we use, and that helps us to quickly realize if there are data errors, improvements, efficiency issues, and looking at trends. And we can share that with partners and use the dashboard to discuss barriers, successes, errors, etc. So having that visualization of what we're actually seeing in live time, or as live as we can be. We currently provide feedback reports on a regular basis related to data quality, completion rates, and outcomes. We work with our partners in any fashion, whether it be phone or face-to-face, or even through reporting on how to use the data to better inform treatment delivery and assist them with decision-making within their organizations. And like I said, we don't collect, or like Laura said, why collect unuseful data if it's not helpful and it doesn't inform what you're hoping to inform? Let's not do that. And so we really look at the burden that we're asking when we collect data. And we communicate that, like I said, either in face-to-face meetings, on the phone. We do quarterly newsletters. We try to have our reports be very nuanced, that have visual data and then maybe more score-like data, because different persons looking at reports want to know different things. So we use charts and graphs to assist with that. And we work collaboratively throughout the entire process. So one factor that we think sets us apart is that we bring partners to the table to discuss the gap, the solution, and how we should measure the success of any intervention, program, or initiative. And really that's important because it creates a buy-in from the very beginning, and we can learn and make adjustments along the way. Next slide. So how do we make the relationship healthy? So we work closely with our partners, not only on about policies, but really making a clear understanding of like the real world applications within the confines of statutory requirements, both at state and federal levels. Really being able to explain the why, being accessible to answer the questions and walk through processes, having a point person, and really building on that trust. And we do not use data as a gotcha. It is to inform processes. And oftentimes when we do talk about our data, it's not, we find, oh my gosh, maybe we can change directions a little bit. And we found that with one of our medication assisted treatment dashboards, that how we were defining or collecting data on medications prescribed wasn't necessarily what was output. And so we were able to improve there. And then communication with partners take work. Don't be afraid to ask the tough questions and go against the grain. It's never an off limits question when it comes to why are we doing it and really what is it helping? How is it helping? And then I added celebration on here, and I don't want to minimize that, is the celebrating the wins. If there is a point that you got all your data in with 0 errors, we praise that. If you had a 2% increase in your GIPRA follow-up rate, we praise that. And we do it across forums, and we say it publicly, and we make those phone calls, and we build those relationships. Next slide. And then what advice would we really give? So if I were to take all the things from the Learning Collaborative and things that we do in Missouri, we kind of came up with a collective response, and that is focus on the data elements that really matter to the audience, right? So understanding that why, because we understand that what gets monitored gets managed, right? So what really matters? Identify automated systems to reduce the admin burden. And as the why maybe starts, it maybe doesn't end where we thought it was, or there's something that we can do differently. We share data freely and openly. We want to encourage that. And that having access to detailed aggregated information for each organization and the statewide number as a whole has helped in a number of different initiatives as well. And then lastly, really wanted to highlight leveraging relationships or leveraging partnerships with partners that have a shared mission and want to build on a data-driven culture to improve care. We talk about data in ways that really reinforces the importance and helps us minimize hurdles along the way. Oh, Gwen, you're on mute.
I think we should start a pool. How many seconds into it will she get the mute off? All right. So go ahead, advance a slide. Our fourth session, we actually talk about improving data from the bottom up. And here we started out to talk about training, technical support, how we emphasize the importance of the quality data and timely and accurate data, incentives, feedback loops, peer-to-peer models, and any technical assistance. I can tell you from my experience visiting the 49 states anyway, The single most effective strategy for improving data from the bottom up is to let the data see the light of day. I'll warn that it can be a painful experience for a state. I know when I've had to do it, expose the data to the world, there comes back this, your data are bad, your data are awful, your data are wrong. But that's the only way that you're going to get your data to a place of high quality, is to make it available, accessible, and transparent to the people that supply it and use it. The other thing that I just wanted to bring up from this discussion, we talked briefly about peer-to-peer technical assistance models. And one thing that I believe I learned anyway from my experience in the state, I used to think that the best peer-to-peer kind of model would be putting your top performer with your lower performer. And boy, they would really, that top performer would be able to help bring that lower performer up. My experience says that doesn't work very well. The gulf between the top performer and the not as top performer is a little bit too big to bridge. We had much, much better luck putting similarly performing providers together. They were really able to talk specifics about things within their systems and unique challenges maybe that they faced. So that would be the takeaway from here. We can go ahead one more, advance one. We're going to give some more examples of this, but my experience in the States, big picture, has shown that there are really two ways that the states communicate information about performance. You can communicate about the performance at a point in time, right now, or the last data collection that we did. How was everyone doing relative to all the other people in the system? Or you can talk about it over time. So how is a single provider or a single system performing relative to itself over time? The thing that is really critical in both systems is to think about the data a little bit statistically. Statistically, at a point in time, your system is going to support a normal range of service performance. Your system should expect to be roughly, and I called it standard deviations, but it would be a little bit more technical, within 3 standard deviations, all of the agencies. If your system is supporting this range of performance, you would see them fall within that range. Someone falling outside of that normal range would be a reason to flag it. Otherwise, you can think that this is the range of performance your system is supporting. So this is just an example. It's really culled from many states and how point in time performance data have been presented. And you can see here, this was for a county system. It might be an intermediary type system. It's where there was an entity that was managing services for a system that had a range of performance and entities. And you can see here, this is arrayed within the normal range. Here's what we expect in the way of performance, and here's actually where performance fell out for this system. This is one of my favorite sayings, and it bears repeating. Half of the entities in a normally distributed system will be below average. It's not something to fear. It's part of the normal performance output for your system. The next way that we talked about looking at data again were over time. And again, another caution, When you're looking at data over time, there can be a tendency to say, oh, performance fell from the last quarter. That's normal too. Performance, I'm sure you appreciate my gestures there. That's your performance over time. It will fluctuate up and down within a range over time. And it's not of great concern unless it fluctuates in the same direction many times over. So if you saw something consistently going down in performance or consistently going up, that would be something that you wanted to flag, but not a single point in time change. All right, we can go ahead. The second thing that we talked about here were use of incentives to pay for high quality data. What we found is within the block grant community, incentive payments are not frequently used. Incentive payments are used primarily within Medicaid systems. The important takeaways we came away with from those systems are that incentives are the things that work, not penalties. Learning theory would say that positive reinforcement will get behavior to change. Negative reinforcement is not associated with a high degree of change unless it's the first time and really harsh, and our systems aren't set up for that. I think I can say our states unanimously agreed that incentives were a better way to implement bonuses for quality data. The second lesson that we came away with was you really need to test any measurement system. An example I can give from a state I worked in, we had a measure of level of functioning. We said if their level of functioning was higher from time 2 back to time 1, we would say their level of functioning had improved. What we found was everybody was identical from time 1 to time 2, no matter what. It was a problem in our system. Our system was actually overriding time 2 data with the old time 1 data. If we hadn't tested and really worked to fix that before we rolled out, it would have been a big problem for our credibility within the system. So testing is really important. And last, involving providers in the planning is really, really important. We as states, not having provider experience, I'll qualify, states with provider experience can understand, but the true complexities, the true way that things work on the ground really has to be understood by the people who are there and who are living it. And involving the providers in the planning is going to smooth things, make it more efficient, improve your buy-in all the way around. It can be one of the most critical steps you can take to put in a program to improve your data. Go ahead. We're now going to turn this over to New Jersey to talk about how do we improve our data. And I'll introduce 3 people here: Clarence Pearson, LeMay Zhu, and I got it right, LeMay, and Suzanne Boris. And Suzanne, I believe you're going to begin the discussion. All 3 of these individuals are with the New Jersey Department of Human Services, with the Division of Mental Health and Addiction Services. Suzanne, I'll let you take it away.
Okay. Good afternoon, everybody. So in terms of our reporting, we have a couple of reports that we post because we want our information to be transparent. And one of them I'm going to talk about is our SUD treatment performance reports. So we have calendar and fiscal year reports that are published on our website, accessible to the public. And these are state aggregated reports and provide information by level of care, because we feel, you can't just lump all the levels of care together. You won't get good information on outcomes. And what this report does, it provides information on a variety of outcome measures, such as abstinence from alcohol, abstinence from drugs, employment, enrollment in job and school training, arrests, homelessness, length of stay, and treatment completion by the different levels of care. So you all recognize these. These are in our TED system. Most of them are in the TED system. We refer to them sometimes as the national outcome measures. Next slide. As I said, they're published on the division website and accessible to the public. And in the performance report, if you look at it, it'll have the information on total admissions to that level of care and total discharges. And it provides information on baseline to discharge outcomes and in the aggregated reports. But there's also a second report. It's a little confusing. We call this a provider performance report. We were required by legislation by Senator Vitale that we had to post annually the performance of every single licensed agency. The first set of reports I talked about are aggregate statewide reports. This one shows the performance of every single licensed agency in the state of New Jersey. And we also did this report by level of care. And it provides, statewide outcomes and every individual agency outcomes so they can compare their performance to the state average. And it shows, it measures the admission outcomes versus the discharge outcomes. So it provides the public in New Jersey an ability to look at a particular agency to see, are they, potentially a good agency with good outcomes or not. So that's another performance measure that's required by legislation. Okay, next. Then another report we do is our SUD overviews. These are calendar reports on our division website, again, accessible to the public. And it provides statistics on substance use disorder treatment in New Jersey. It has treatment admissions and discharge data statewide and by county and by municipality. So if you go to our website, there'll be an overview, an overall state report. And then under that, for that year, there will be an individual report for every single county. And when you click on a county report, you will see data on the municipalities within that county. So that's very useful for our county planning processes. And these reports now include trends and tables and geomaps. One of the things we will what we're going to be doing this year, our first attempt at this, is we're going to produce a dashboard on some of the key variables and like primary drug and level of care. And we'll have filters, such as by county, by age, by gender. So we could see if there's, and race, ethnicity, to see if there's differences based on different target groups. Okay, next. To help improve our quality of data, we do this regular reporting. We listen to questions from stakeholders. We make sure we clearly define our data fields. We have a code book. We do regular data analysis for monitoring and cleansing data. Often we will see data that makes no sense. And then, we're able to go back into our database to see what the heck is going on, so we can make sure we put the right controls in so we don't produce data that makes no sense. We have training and communication with providers. We work with our IT group to help improve our data architecture. And as I said earlier, this is the first time we're going to be working with designing and developing dashboards. So any state has examples that they're using right now on their treatment data. If you could send it to us, we'd be very happy. And next. So what I would say to states, is make sure your report has a clear purpose, that it's focused, not all over the place. Make sure you've employed data quality control, advertise it to audiences and make it accessible to the public, and, entertain feedback from providers. Let's see, do we have another slide? I think that's it.
All right, well, thank you. I got the mute button. I'm very pleased to announce our fifth collaborative was on the topic of recovery journey. And we're very thrilled that we are going to be joined today by some real experts in the field, the Georgia Recovery Support Clubhouse team. So they are going to share with us their model and their reporting strategies and how it has all worked for them in Georgia. So with no further ado, Brittany, take it away.
Hi, everyone. My name's Brittany. I'm at the Georgia Health Policy Center here in Georgia. And so I'll give a little bit of input into what we're doing here. So the Recovery Support Clubhouses were established in 2008. They are funded by SAMHSA and implemented through the Georgia Department of Behavioral Health and Developmental Disabilities, or DBHDD. Essentially, they were started because DBHDD noticed a lot of challenges with youth who were cycling in and out of programs, especially if they weren't mandated to attend. So they requested some more funds for a more non-traditional clubhouse program for youth. And with that, they were able to establish 9 different sites across the state, with sites in both rural and metropolitan areas. So next slide. The program model does have a lot of components, but is largely conceptualized as a continued care program for youth who are 13 to 17 years old in recovery who may have received substance use treatment in the past, but it's not required. The model engages youth and family involvement in the recovery journey, recognizes youth as an individual, and also includes an aftercare component. There are 6 outcomes that are identified by SAMHSA for the clubhouses to adhere to. These include decreased substance use, juvenile justice involvement, and behavior problems, as well as increased positive social functioning and school attendance, and improved family relationships. In order to help youth meet these outcomes, the clubhouses do have a lot of creativity with their programming. These often include different types of outings, trips, theme parks, peer support, therapy, family engagement, as well as transporting youth to and from the clubhouses. So next slide, please. The overall purpose of our evaluation, and essentially what we do, is try to better understand the influence of the Clubhouse program on youth and their families, as well as support peer learning across the 9 sites and help inform decision-making for our sponsor at DBHDD. Working with youth in recovery means that we're really not pulling from a well-defined evaluation of what works and what doesn't. We know that youth in recovery can be a really tricky population to serve, especially to serve well. So what's really driving this work is that we're all essentially learning together, both from our team here at GHPC, as well as with the providers across all of the 9 sites. So our evaluation plan does use a mixed methods approach to highlight program data as well as outcomes. These include some quantitative data, which uses clinician and youth level data that's entered into a portal that we designed for the sites, as well as some qualitative data that are in-depth interviews with youth and their families, as well as the youth-defined goals. Next slide. So how we collect the quantitative component of this evaluation involves receiving secondary individual level data that's collected from the program sites. We created a portal using Azure that houses data using a SQL Server database. We also do provide all TA for the portal for all of the sites. So that ranges from if somebody is locked out of their account or if somebody is new to the sites and they need like a portal guide and essentially a know-how to use the portal, we do provide all of that. The purpose of this portal is, of course, to support Clubhouse program management and ensure quality improvement. What goes into the portal includes demographics, participation and attendance, drug screenings, as well as some CANS assessment data. And of course, since the clubhouses do seek to be youth driven, they also enter youth defined and identified goals into the portal. Based on staff needs, there's 2 different components of the portal that we've helped design, one of which includes data dashboards. These dashboards provide real-time availability of aggregate data across the 9 sites, which are really great for the sponsors to be able to look at, and provides real-time accuracy of the data. And then second, there are youth profiles, which are still in development, but they do act as individual client records. The youth profiles, similar to the data dashboards, but they do provide real-time availability for individual level data. They also provide what we hope would be better outcomes tracking for the staff, as well as a tool for meeting with family and their youth. We've also designed them to, most importantly, provide non-linear visuals for the youth and the staff that really will mirror the youth's recovery journey. Next slide, please. In addition to the quantitative data that we collect within the portal, we do conduct interviews with those receiving and providing services. So this does include currently enrolled youth, graduates of the program, caregivers of currently enrolled youth, as well as staff and the directors of the sites. We conduct these over the phone on an annual basis, and they are incentivized. The qualitative part of our evaluation is really our favorite. Most of us are qualitative experts, so we really love this part. And we think that the in-depth interviews really shape the overall evaluation and provide that needed context for the youth recovery process, because really we're getting information directly from the source. The interview design does include a trauma-informed guide and further highlights youth voice and choice, which we feel is crucial to capturing the entire recovery process. So this data collection design does help us meet youth and their families where they're at, as well as providing direct feedback to the staff and to our sponsor about barriers or facilitators to the recovery success. So next slide, please. So when capturing data points related to the recovery journey, there's a few key points that we have made as suggestions to kind of keep in mind. You will want to create a tool that does, of course, work for all staff, and you will want to get full input from the staff since they'll be the ones using the tool. And you want to create something that doesn't have an additional burden by asking folks to put data in multiple places. In addition to that, you will, of course, want to provide accurate and timely TA and routinely check in with staff, as well as use approaches that really drive instead of hindering program implementation. Your methodology is also really important and should be chosen based on how well it can capture and display your program outcomes and highlight the recovery journey. So we just say feel free to get creative if you need to. We were able to do that with the in-depth interviews, and that really helped provide us with a lot of important information. Lastly, data rarely arrives neatly packaged, and we think that that's fine. We recognize that these kind of things take a lot of time. Our program evaluation didn't happen overnight. It actually took about 5 years for it to launch and then to be implemented. And it routinely does go through enhancements as our program needs change, both across the sites as well as the youth that they're serving. So ultimately, you want to ensure too that lived experience is included. This is really going to be foundational to the types of data and the quality of the data that you're capturing. So this can include highlighting participant voice and choice and being aware of any sociocultural factors that might be relevant or impacting the recovery journey. And as our team likes to say, like, we believe that people provide data, they're not necessarily just their data points. So with that, I will turn it back to you, Gwen.
All right, thank you. So I don't know about anybody else, but I feel like we have been through a lot of stuff in a very short time. We have one last learning collaborative to report to you about, and this was really the summation of our other 5 learning collaboratives. We came together and each of the states told us, how do we tell a story with our data? Some of the points we wanted to discuss during this session, we're talking about maintenance of effort, benefiting the entire state program, and then general improving quality. But the one that struck out for me anyway, thinking about telling a story with our data, I didn't quite see how maintenance of effort fit in there. But the more I thought about it, the more that maintenance of effort shows the state's deep commitment to behavioral health and substance abuse services over a long period of time. And that is a really important story to tell, how much our state has invested in this, how much our state cares about this story. So with that said, I'm going to just go ahead and turn it over. We have Ronna Corliss and Sissy McKenzie, who are with the Kansas Department for Aging and Disability Services. And I think they're just going to pull this all together for us, right, Ronna and Sissy?
You bet.
All right, take it away.
Okay, I think Sissy's going to go ahead and start with us here.
Sure. First of all, I want to say thank you to Dr. Grams, JBS, and SAMHSA for allowing us to present today. Okay, we're on the correct slide. Okay, first on open disclosure, Kansas is modernizing its substance use disorder data collection system. So our reporting is continuing to evolve, but what I really want to talk about today is the infrastructure we have for our reporting. As many of you know, we are federally mandated by the Mental Health Block Grant to have a Behavioral Health Planning and Advisory Council. In Kansas, our advisory council is called the Kansas Governor's Behavioral Health Services Planning Council. So the council includes representatives from many different agencies: behavioral health, education, rehabilitation, criminal justice, housing, social services, and our state Medicaid authority, which is KDHE. It also includes public and private entities. It also includes providers. And most importantly of all, the council includes adults and family members with SMI or substance use disorders who are receiving our services. Next slide, please. Much of the work of the Kansas Council is done by volunteers and subcommittees who make recommendations to our Secretary of KDADS. Those recommendations are reviewed, they're posted on our website, the reports, and they're shared with the governor, with other legislators, and other stakeholders. And in Kansas, we are very fortunate to have a really strong Governor's Behavioral Health Services Planning Council. Our council has several subcommittees. Some of them are a little older, some of them are a little bit newer. We have a children's, service members, veterans and families. We have housing and homelessness, employment supports, justice involved youth and adults, prevention, rural and frontier. What we have for substance use disorder is called the Kansas Citizens Committee on Alcohol and Substance Use. This was a legislative mandate subcommittee, and it was kind of rolled in under our council. And some of our newer subcommittees include the evidence-based practices, the peer, and the problem gambling and gaming. And each one of these subcommittees includes not only interested stakeholders and peers, but they also include a behavioral health services liaison to that council. So under the KCC, which is the Kansas Citizens Committee, our substance use disorder subcommittee is what's called a quality committee. And what the quality committee does is we have in Kansas, we have 3 Medicaid managed care organizations. And then we have 1 for the substance use disorder block grant, now SUPTERS. We have an administrative services organization. So what they do is they review contractor data. It's de-identified and aggregated data, and then make recommendations based upon that data. Next slide, please. The data from the contractors is collected in their system from provider claims and then reported to the state in aggregate. What's important to know is the quality committee is provider-led and reviews the data and makes recommendations to us. And as I said, we're kind of in the middle right now of a modernization of our data, but a couple of examples of our data is one is we have what's called a preferred kind of like a drug of choice report that kind of talks about the people we serve and you know, their preferred drug, and it's an aggregate, and it separates into higher and lower levels of care, as well as by statewide and then by regional, so that we can look by trends over time to see what is the reason people are coming to that are needing block grant services, needing treatment services. So we've been able to see that it used to be over time that primarily the youth were seeking services for marijuana, and then for adults, it was primarily for alcohol. And then over time, we were able to see that primarily people were seeking services from the block grant for methamphetamine in our area. And then alcohol was taking us, you know, was second. And now it seems like as fentanyl is coming, we're able to see kind of the emergence of both drugs for people seeking services from block grant. So that's one of the reports we have. Next slide. So one of the reports that our administrative services organization developed was called like a provider, they called it a provider report card, but basically what it did is each provider got aggregate data on their specific information, such as people served, demographics of those people, and national outcome measures. And it was kind of measured against the state as a whole. So basically against their peers, so that they could kind of see how they were doing on the information being reported. At this time, when the providers were, when we changed over and started modernizing the data system, providers were wanting to get more specific information. So our quality committee, which is provider led, worked with the ASO and the 3 MCOs for CanCare Medicaid to develop this report. And I think what was the most challenging in that development was making sure everyone had the same definitions to report. So today, this
It was
report
very
has been
beneficial to have
developed.
their input, the MCOs, the
Yeah,
managed care opt, you know.
yeah. So today, these reports are being developed, they are implemented, they are going out to providers quarterly. So that would be probably it'll be interesting to see how these evolve over time. I would like to see eventually our national outcome measures also being reporting again to providers as our data collection system becomes more modernized. Next slide, please.
And it's been very helpful as well as far as looking at our state regionally, because we have a huge part of the state, which of course is, you know, frontier and rural. And then we have a chunk which is very urban, the Kansas City, Wichita areas. You know, so when you break it out regionally and you look at providers, it helps, it puts a different perspective on it when you look at it regionally.
Okay, so our takeaway from the collaborative is, again, I'm reiterating that we're in the process of modernizing our data collection system, and we have a vendor chosen and development is underway, but networking with other states that are also, you know, also working through their modernization and kind of understanding their opportunities and challenges and being able to, you know, eventually collect data in a more meaningful way has been very helpful. So, and hopefully will help inform our new system. So we appreciate that very much. Thank you.
Yeah, and I think the providers are, you know, are seeing firsthand the value of the data that they're collecting and why, you know, we're on their case about the TEDS data or why, you know, we're harping at them for other things. And, you know, it's finally kicking in, they're seeing the benefits of their work as well on data collection, which took a while.
Thank you.
All right, and I see actually now we need to be a little bit more concerned about time. I will try to summarize what we've discussed here in 2 sentences. 1, states are different, but 2, we have overarching strategies and practices that will work when they are tailored to the state system. And leave that summary there, and I guess we'll go to questions and answers.
Thank
Matt,
you,
you're
Dr.
moderating.
Grams. Thank you, Dr. Grams. And again, for all of our state speakers this afternoon, a very big thank you for taking the time to lend your expertise. So at this point in time, we will begin the question and answer segment of the presentation. If you have not already done so, please submit your questions by using the Q&A feature located at the bottom center of your screen. Our first question: what recommendations do you have regarding explaining or presenting complex data to diverse audiences? Again, that question is, what recommendations do you have when it comes to explaining or presenting complex data to diverse audiences?
And I'll take it away to start, Matt? How's that? And if any
Great.
of the state representatives would like to jump in, please feel free, because I think everyone wants to hear from you. But I think the things we discussed about really tailoring to the audience and making sure that your audience or is concerned about the message that you have to present, and that it can be arrayed to them in their own way of understanding things. So if I'm a data administrator, I might understand a little differently than the clinician, but really, really thinking about the person that you're having to communicate that to, and then working with them. And was that a two-part question, Matt? I think I got one. Was that it?
Yes, just
Okay.
strategies for explaining or presenting complex data.
Tailoring and keeping simple are the two best strategies I can think of. Any of the states want to join in? I guess we tailored that and kept it simple.
I can say what we're doing here in Georgia is we actually collaborate with the staff. So they have a lot of input into how we put together the data and the types of stories that they want to tell, so that it's best reflective of the sites and their experiences.
Thank you, Dr. Taylor. Thank you, Dr. Grams. Our next question: how have states been successful in data sharing with the justice system? That question: how have states been successful in data sharing with the justice system? And maybe even, taking that question and thinking, just developing good working relationships with other partners, other providers even.
All right, now I'll actually start off again, because this was my baby when I was in Oregon. We developed a shared data system starting out with our criminal justice partners, which we later expanded to a shared data system with, I think, around 25 other data partners throughout state government. One of the lessons I learned from that, and we'll share with the other states, is that we as a substance abuse agency started that, but as soon as all of our partners saw how valuable it could be, they surrounded us and they started wanting the data for themselves. And it really became something that became much bigger than substance abuse. And I can say the state where we started this in Oregon, our criminal justice system took it and ran with it. We had our judiciary was involved in trying to take data and look at how could that guide them on some of the choices that they were making when they considered client background. We had them trying to make systems that could accurately predict good placement decisions within the system. And so it's really something that grew and is still in use today, from what I know, which has been, I think, going on 20 years. The really critical component from that, the thing I think we did right, was that we built the integrated data system in such a way that we could easily link it back to all of the legacy systems that provided the data. That made it in our partners' interests to participate, because they could get back to their data and they could see their data in the context of all these other services and programs. And it just got to be a win-win, self-reinforcing all the way around. Any of the states, would you like to join in and add something to that?
I'll share
ahead, Laura.
something. Thank you. So DC doesn't have a shared data system, which sounds incredible, but we do have a dashboard that incorporates data from our Department of Corrections and integrates it with our SUD treatment data, our fatal opioid overdose data, and our non-fatal opioid overdose data, so that we can, find the same people across all those data sets, and we visualize it at an aggregate level, obviously, It's not public, but it is available for government partners to utilize. And, we were very much able to work with our Department of Corrections because they're extremely motivated around opioids. They have a number of initiatives in the jail, and it was something that really benefited them to be able to see that matched information. And we can monitor how quickly are folks leaving the jail and then getting to treatment. What is the time between leaving jail and a fatal overdose, and what can we do to try to mitigate those risk factors? So having that shared goal was really helpful to get them to be a good partner.
Thank you, Laura.
Thanks,
Our next
Laura.
question.
Oh, Matt, I did want to jump in with one more thing too. I'm sure our CSAP partners would want me to bring this up. There are many different kinds of data sharing pieces, requirements like HIPAA and confidentiality. The thing we discussed in the collaboratives is those things are not there to prohibit us from doing legitimate research that helps us improve our services. Those things are there to protect our clients. And if we are following those guidelines, we can share data in an integrated way and learn from it and protect our clients at the same time. So those things are there to help us, not to be barriers to integrated data.
Thanks, Dr. Grams. And just in the next 30 seconds or so, our final question. Do data partners take accountability for incomplete and or missing data?
Whoa, that feels a little low. My experience has been very much yes, when the data see the light of day. When data are reflected back to the people that supplied it, they will notice immediately if the state got something wrong and will point it out to you. And when it is no longer that it is the state has done something, they, I promise, will notice immediately and act on it if they see that they do not believe their data are putting them in a favorable light. Anything to add, States?
Thank you, Dr. Grams.
I would like to add that we have, many of our providers are very long-term providers and very passionate and very committed to doing the right thing and serving people, and are also interested in the data. I mean, our subcommittee really is led by a provider who missed the data we had that was more comprehensive before we went through the modernization. So, they also recognize that it helps inform their systems and they want to improve as well.
Thank you, Sissy. And with that, we will go to our final couple of slides to wrap up the day. For states who are maybe interested in getting some technical assistance, the way to do that is by reaching out to JBS via our email, which is samhsateta@jbsinternational.com. Next slide. And this would not be a quality webinar on data if we didn't in turn ask you for a little bit of data. So with that said, we do ask that folks complete an evaluation for this afternoon. You can do so by clicking the link, which is now available in the chats, or by scanning the QR code on your phone. So it's just a handful of questions. We would really appreciate your participation in that evaluation. As we exit today, that evaluation link will be open. So as the slides change, no worries about that evaluation link being closed. So again, the evaluation is available via the chats or via the QR code located on your screen. Next slide. As we finish up today, a big thank you to Dr. Grams, our fearless leader for many months now throughout the Learning Collaborative. Your passion and enthusiasm is contagious, and we very much appreciate your leadership over these past few months. To our state presenters this afternoon, another big thank you for taking the time to lend your expertise and insight gathered via the Learning Collaborative to other folks. And to our attendees this afternoon, thank you for taking the time to be here. Your attendance is indicative of your own passion and efforts to improve your states. So with that said, thank you.
Oh, and to add one, I also want to thank CSAT so much for sponsoring this. When I was a state employee, I would have so much appreciated CSAT providing me with this opportunity. So thank you.
With that said, have a wonderful rest of your day. Take care.